Thank you very much, and thank you for inviting me here today. Let me just get my slides going. Just a quick, it's not always great to be the first person to speak after lunch. So just to make sure everybody's awake, just a quick show of hands. How many of you have heard of or have some idea of what open dialogue is? Hands up. Okay, that's pretty much everybody. Okay, good. So I don't have to start from the beginning and teach you all about open dialogue. That's good to know. Okay, so now I was hoping, when I was invited to come here today, I was hoping that I had a fantasy about coming along and telling you some wonderful results and having a great celebration. Unfortunately, I have to start with an apology. I don't have the results yet, I'm afraid. After about nearly 10 years on this journey, the Professor of Statistics, Sabine Landau, who is now in charge, because she's crunching all the data, she said to us about 3 weeks ago, listen guys, after all of this time, don't you think it's important that we do it right rather than do it quickly, and give us a couple more months to get the results right? So unfortunately, we won't have the results till about autumn, so sometime in the autumn. We had hope for spring, but we don't have the results yet. And I generally don't know. Those of us involved in the trial are regularly getting accosted by people on the streets to find out what the results are. This literally happened. So Steve Pilling, who's the chief investigator, the lead academic for the trial, was taking a walk in Hampstead Heath, which is a famous park in London, and the head of mental health in England, Claire Murdoch, literally accosted him, pushed him against a bush, and said, you must know the results. Come on, don't lie to me. We need to find out. I said, honestly, I don't know. And none of us know, actually. It's all blinded. What will happen is, at the end, the statisticians will say, the winner is A, and they have an A or B, and then we open the envelope to find out what A is. Is A open dialogue or treatment as usual? So everybody's blinded, and we're not allowed to know. And I also don't know, because I work in the open dialogue side. I don't know what's happening in the control group. So, yeah, I'm sorry. However, I do have some experiences to share, some papers we've already published, and also a story to tell. So I'll share with you the story, and I'll bring in the voices of the people who've been involved in this project from the beginning, so you see and hear from them rather than just me. So let's start with the problem and why this came about. It's already been mentioned during the open forum earlier that the UK has been going through a very, very difficult time in our public services. We entered a period of austerity in 2010, and although theoretically the NHS was protected, it wasn't really. And because of that, we've experienced substantial cuts and reductions in our services that we provide in mental health and healthcare in general. This has led to a recruitment crisis as well nationally. As you know, we had COVID. In 2020, we had the highest exodus of staff leaving the NHS than any time since the NHS's founding. So we have a major recruitment crisis. Staff morale is very low. We've had a series of scandals where documentary makers, people have been secretly filming what it's like to be on an inpatient ward in our systems, and that has led to a great deal of consternation about how inhumane and lacking in compassion most of our services are. And the wrong conclusion is that this is just a few places. It's actually fairly systemic in the way that our services are not providing very compassionate care. And so there is a widespread understanding that our system isn't working. Now, one of the first questions that we tried to research is open dialogue a potential answer to all of these things? So what we did is we did some surveys of members of the public, of people who use services, service users and the carers and others, as well as staff. And we put forward the core principles of open dialogue, about continuity of care, about working with networks, about the importance of the relationship, about tolerating uncertainty, all of these things we listed out, and we asked people, do you think this is a good or a bad thing to be in our mental health system? And there was a strong consensus that people across the board believed this was all good. You know, this would be good if it existed. But at the same time, there's a strong disagreement that any of that exists in our system as it stands. And that has also been my experience. So when I first learned about open dialogue, I don't know, something like 15 years ago, it seemed to be the answer to all the questions I'd been asking. How can we have a model of care that puts relationships at the center, that is focused on cultivating the relationship with the person and their whole network, that teaches everybody to focus on that first, and not think that it's somebody else's job to develop a relationship. I have to just fish for symptoms or prescribe medication. Where can we find a system that everybody is involved in working systemically, and working in a person-centered way? And when I found Open Dialogue had been doing this, I was immediately euphoric. This is exactly what we need. However, I was also instantly depressed that I can't see how this could ever work in the UK system because we're so far away from that. So I spent a couple of years almost wishing I hadn't seen it, really, because if you see what things could be like, then it almost feels worse. And then I got promoted and got made a clinical director and various other things in my local area. And I realized that actually everybody else at the senior levels of the NHS realized that the system doesn't work either. It's not just something a few of us think. At the top level, everybody knows this. It's like we have a big indoor where lots of people come in and we don't have any outdoor. So we just have a ballooning system with more and more people struggling long-term ill without actually having a way out. It's a bit like joining the CIA. Once you're in, you can never get out again. And so I was able to make the case to some people and say, look, why don't we do something radically different in one corner of your organization? And people will say, oh, evidence-based, there's not enough evidence-based, there's no randomized trial. How can we trust it? And we would show the data from Finland, and they will say, well, how do you know the weather didn't change or the water didn't change? And that's what caused the results. And unfortunately, that's the way that academics think and policymakers think. So we forced down the road, okay, let's think about how we can do something about that and try and engage in some research. So the first stage was to engage in some training. And we trained people from across the country. It started with Val, Mark and I in the UK having a chat with Jaakko and others about how can we actually launch a training that's at 1 year that gives people a foundation in open dialogue, that enables them to gain some of the basic ideas and start working with them. And so we developed a 4-week residential course. It was the first one in the UK. And we flew in some of the Finnish trainers like Jaakko and Mia and also Mary Olsen from the States. We have tutor groups, so these days we tend to have about between 100 and 200 people training each year. It's based at Cambridge University now, and we have people flying in from around the world. And as well as the main plenaries, we also have smaller tutor groups. We have online training in between, and our training is accredited by the Association of Family Therapists. It's mainly team-based, so we tend to encourage organizations to fund whole teams so that you can really change the center of gravity. Now, when we started training teams, they weren't all people who were very enthusiastic about open dialogue. In fact, most of them had never heard of open dialogue. They didn't know what it was, but their organization had been pitched by me, and they'd suggested, okay, let's give this a try. Let's send some people on that training. And if you ask most people before the training, what do you expect to gain from this training? Most of it was, well, a week away from the kids, or having some drinks with my friends. They didn't really have much expectation beyond that. So we didn't pick a cohort of people who are, really wanting to do anything different. But what we found very quickly was that people started to take and embrace the model very passionately once they went through the training. This is one of the first cohorts of trainees. Almost everybody here has been involved in the ODDESSI trial. The people who trained back in 2014, 2015, 2016, they were the people who then helped us forge the pilot team. So these are the faces that are behind the whole trial. There's probably twice as many as this, but these are the original ones. And before the training, we would hear things like, what is open dialogue? I have dialogue with my patients, so what is this about? I'm not sure why I'm here, really. This is the problem with the name open dialogue. Everybody thinks they do dialogue. So it makes you think, well, what is there to learn here? But in the middle of the training, most people would be saying, actually, this is very different. And then at the end, this is the kind of thing that you'd hear. So I've got a video here. I've lined them up. Hopefully this works. Hopefully you can hear it. Let's start with this.
There is a really big need and request for staff members to have a new way of working. And I think that people are a bit tired of this kind of over-medicalization of the system and really are looking for a more humanistic and democratic ways of working.
A lot of people have said to me, if it wasn't for this training, I would be thinking about leaving not just my job, but this profession. Because, they're burning out maybe, but they're also just feeling like they're not doing what they wanted to be doing.
Open dialogue has helped me get back to that original way of being as a social worker, as somebody who's there to advocate and help people get to a place that they want to be at, that they're comfortable at, with themselves, with their family, with their community.
It really struck me that this was the way that I wanted to work. And as I went through the training and started to see families using this approach, I think that's just become more and more reinforced.
Just going and trying it out lets you know how possible it might be to carry on. And I think it's certainly given me the enthusiasm to continue and to pursue it.
This is the first open dialogue course that has been taught in the NHS, for the NHS and by NHS staff. We also combine it with the international open dialogue trainers from Finland and from America and other countries who come and teach us about how it's done there. So we bring some of the international big names and experts to help us understand, but also ground it into local professionals who can talk about how it is actually done locally, because for the first time we are.
Trainers embody open dialogue. They are people who live open dialogue, and that's what I aspire to do, and how that, I mean, that's been the major change in my life over the last year since the course, is that I am becoming much more dialogical in my own life. And to me, you know, as soon as they walk in the room, they embody that, and I was like, yes, that's what I want to be.
And when you have a training that brings together sort of professions from across the board, whether it's a psychiatrist, whether it's a psychologist, whether it's an OT, whether it's a support worker or a peer, there's room for every voice to be heard within that space. And that is something completely different to anything I think is on offer in the UK.
This way of working seems to trigger kind of unpredictable but positive movement and trajectories in families that you can't really anticipate from the outset.
If you strip it right back, the actual theory seems to be quite simple, really. What you might do with a friend, as a close friend who supports you, but they're enabling you and allowing you to unpack the stuff that you're having difficulty with and letting you go with that, however difficult it is. Because sometimes we need to go through difficulties to come out the other side.
So actually being present with pain rather than trying to remove it, and allowing people to grow through their experiences rather than trying to just take them away from it.
Quite deep personal experience, which is both intellectually stimulating and emotionally, well, I suppose I'd use the term emotionally quite moving.
It's been beneficial professionally and personally, and what's happened is there's more of a blurring of the boundaries between the professional and the personal, and actually allowing the personal to influence the professional.
The way that these ideas and practices have allowed my own clinical work to blossom. And that's really what I want to, give other people.
I feel myself very fortunate to be able to share my experiences, and that makes my work in teaching this very, 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 very valuable for me.
I think this course is an opportunity to be part of something that is going to change the way that we do mental health work. And I think it's a very exciting opportunity.
Your satisfaction going home at the end of the day when you've had a network meeting, when you've connected with someone, is going to be sky high. You will feel a sense of achievement, you will feel like you've helped someone, and that's an amazing feeling.
I'm doing something changing somebody's life. This is what I wanted to do.
Sometimes I think, I think I'm part of a program that I think is going to go international, and people are going to be talking about, 2015, 2016, and I'll be thinking, yes, I was involved.
Okay, so those are some of the people who were involved from the beginning. And what we then needed to do really is to think about how we can try and properly evaluate this. So I went around hunting for academics, basically. We went to different universities and different senior academics, and then I went to meet Steve Pilling. Now, Steve Pilling is responsible for writing our mental health guidelines in the UK. So I only went to meet him because I thought I wanted to tell him that one day I'll come back with an evidence base that will make you have to add this open dialogue into our guidelines. And I don't know if anybody's ever watched Dragon's Den, you know, when people make a pitch for money to an investor. Anyway, I was making a pitch to him about how, you know, this is something I think you should pay attention to, and one day we'll bring something back to you. And halfway through the pitch, he started to pitch me, and he was saying, well, actually, I think this is really important. And we tried to do something like this when we set up the crisis teams, and we failed. Why did we fail? I said, well, you never trained people to work systemically. And so he said, look, well, I mean, I have a whole team here. Perhaps we could get together and try and work on this trial together. So, well, if you want to be the academic lead, that's fine. You know, great, go for it. So Steve then helped us put together a very, very ambitious grant for to the NIHR for £2.9 million, together with a whole range of academics from UCL, King's, Birmingham, Middlesex, and Oxford as well. And it was a cluster randomized design, meaning that when people are in crisis, you can't really randomize as the individual comes in, because you can't, you know, interview them and decide which side of the trial they're in. So it's randomized before anybody enters the service. In other words, it's randomized by address. So we had to pick certain areas, like Havering is a part of northeast London where I work, or Waltham Forest, and we basically drew out certain geographic blocks in each of these areas that had roughly equivalent referral rates, roughly equivalent illness rates in those areas. And half of those blocks would be open dialogue, half of them would be treatment as usual. So there's no way you could know in advance. It's going to be randomly decided. I thought we could decide this just by flipping a coin, and you say, okay, these areas are open dialogue, but the statisticians wouldn't allow that. We spent £40,000 on an algorithm that at the end told us, this is open dialogue, this is treatment as usual. So that's money well spent. This is how academics spend money. Anyway, so finally we knew which areas would have open dialogue, which areas would have usual treatment. The things we're going to measure are time to relapse. So if you have open dialogue, do you take longer to end up relapsing, or do you hopefully not relapse at all, or come back less often over a two-year period than if you have conventional treatment? The main thing is relapse. We want to show what Jaakko and others showed, which is that actually your relapse is reduced, you know, your return to service is reduced. And also, we are looking at things like hospitalization, people's personal agency, their social network, size and depth, medication use, functional outcomes, the whole range of outcomes that we're measuring. The main one is time to relapse, is people's relapse rate, which we're measuring. Now, the study aims to, this is what we formally wrote in the application and what's on our website. So the study aims to transform the current model of mental health care for patients with mental health problems. The research asks several questions. Can we develop a way to offer open dialogue in the NHS that is acceptable to staff, including peers and service users? Can it fit with how existing NHS services operate? Because no one's ever run an open dialogue service in the NHS before. So does offering open dialogue result in good clinical outcomes, and is it worth the money? What is the experience of service users, carers and staff? So those are the three questions the trial is effectively asking. Now, can you win such a large grant for a model of care that has never been tried in this country, in the UK? Usually the answer is no. And this was a very, very daring bid on our part to try and get money for something that has never been tested. There's not been any research done in the UK before this. So you can't go from no research to £2.9 million massive randomized controlled trial. But we tried it anyway. It's a bit crazy. But we gave it a go. Steve and most of the others thought we probably won't get the grant, but you know, at least we'll get some feedback. So we awaited the results, and the deadline came for the feedback, and it was the day of the deadline, and we assumed, okay, we haven't got the grant because they haven't fed back to us. So Steve called the National Institute of Health Research and said, we assume we haven't got the grant, so it'd be good to have some feedback. And they said, what are you talking about? You should check your junk folder. So he went back to his junk folder, and there was the £2.9 million grant. And also, they had said that if you don't respond to us by 5 p.m. on this date, then we'll assume you don't want it. So just as well, he found out just in time. And so we got the grant, luckily. And now we're running the largest trial in open dialogue. Not only the largest trial in open dialogue in the world, it's also the largest model of mental health care trial in the world today. as well. Very large trial, and thus ODDESSI was born. ODDESSI stands for, I don't really understand the acronym myself, but Open Dialogue, Development and Evaluation of Social Network Intervention for Severe Mental Illness. Academics do really enjoy the acronyms, so Steve really enjoyed this bit and came up with this name. Now, launching the teams was not an easy thing because we were training people to work in a very different model and going to evaluate them as soon as they went back to work. So it's a little bit like trying to fix wings onto a plane while it's on the runway. Okay? It's not a very easy thing to do if you've ever tried it. So we had to try and get the teams working. Not only that, but see if we can evaluate these teams at the same time as getting the teams working. And so we launched one after another team. The key to actually getting the teams working was vertical alignment across the system. You need the executive at the top to be on board. So I spent a lot of time in the early days going to chief executives and to trust boards and making the case to them, look, why don't you get involved in something that could change the whole system? At least you'll be ahead of the game. And a good number of them agreed with that. We had to construct a whole new care pathway. It's not enough just to train the staff. They have to work differently so you have continuity of care and you don't have people going from one team to another team. So we had to train people across all of the different teams that might be involved and form a network around the service user. We wanted peer workers in every team. That's why we call our model peer-supported open dialogue, because we thought this would be essential, really, to having a culture in which we value lived experience and give a space to lived experience. Because fundamentally, what open dialogue is about is creating a space where different voices can be heard. And we wanted to make sure that our team culture also involved hearing those different voices. And so we brought them into our teams as well. The team leader and manager and psychiatrist also had to join the training, because there's no use everybody working dialogically and then the psychiatrist and team managers doing something differently. It wouldn't work. So they had to bring them into, the team started to come together and galvanize through and after the training. We also, so we managed to recruit teams from various parts of the UK. So we've got North East London, where I work. We had 2 teams there. One in outer London, Havering, one a bit more closer to inner London, Waltham Forest. Then we had Haringey, which is even further into inner London. Then we had Camden, which is absolutely right in the middle. It's core inner London, very urban inner city. Then we had Kent and Medway, which is sort of semi-rural, sort of out there. And then we had Devon, which is even more rural. So we had a nice spread between very, very urban and very, very rural, different demographics, different populations. And it was a very nice combination that we managed to do. And obviously my site was the sponsor site. Now, one thing just to say is that it was as much about learning new ways of working as it is about learning a new culture for the team. And so we had this culture of nothing about us without us. In the team, we would discuss our clients very differently. We would have this reflective space where clinicians would reflect on their subjective experience. In the same way you do in a network meeting, we use reflections in our team meetings, instead of just talking in an objective space and making decisions about people without them there. So we just have reflections which we can then take back to the network meeting. So self-reflection was a key aspect of all teams. And it really did affect people. They started to work very differently, and they noticed how this was different from the beginning. So I'll play another video from one of our teams. This is the Devon team in Torbay.
I'm continually impressed and gladdened by the way the staff in the community work and their attitude, the way in which they really embed themselves within the community that they're delivering the service for. The work here, though, it would be false to suggest that it's anything but busy and at times feels almost overwhelming. Despite that, people are still up for trying new things, and that is very encouraging, such as open dialogue, which interestingly actually arose in Finland at a similar sort of time of austerity. And here we've got a team that are willing to take on additional work and scrutiny and change, in a sense, to really try and improve the outcomes for people using our service, which is extremely gratifying.
Open dialogue is an approach which involves working with a person and their network, so that is their sort of family network and social network. The decisions made around their treatment is happening with that person and their network in the same room. Devon Partnership Trust are going to be part of a randomised controlled trial which is going to start in January 2019. The research is focused on people with psychosis coming into the service. While we're doing the training, we've had a chance to practice, so I've been offering this open dialogue approach to people we're already working with.
We are learning a different way of working with people that puts the person at the centre of what we do. If a referral comes in for somebody within 24 hours, then we will look at arranging an open dialogue meeting, and the person is at the centre of who they want invited to that meeting. At least 2 people from the team would go along to that meeting to support that dialogue to open up. The feedback that I've had myself is that people feel listened. It opens up conversations that maybe they've never opened up, even with people that they're really close to. And I've had a couple that have attended on 4 sessions now, and each time something new comes up that they haven't spoken to each other about until they get into that meeting.
I've spent the best part of 35 years involved in mental health services in one way or another. In my early years, I was sectioned 4 or 5 times. I have complete experience of mania, depression, hearing voices, broadcasts, you name it, I hear it. I've tried studiously to get jobs time and time again, and I have a degree in law. I speak French and Spanish, and in spite of all that, and each time I've applied for jobs over the last 20 years, given that my system works so fast, I've been rejected when people have seen employers, none of them have been mindful employers like Devon Partnership Trust, and have rejected it based on medical evidence that they've got. And I'd heard of open dialogue before getting a phone call asking me whether I'd be interested in being the peer support worker. I was offered the chance within this team to both be myself and offer my experiences in a very constructive and positive way. So given what's happened in my past when I've applied for jobs, this was both a show of hope and faith and trust in me.
For me, I think it's right. It's the right way forward. I think it puts people back at the centre, bring their own ideas. They're driving their own recovery with the people around them that are supporting them, their network.
So the aim is that the people who we're working with will really feel listened to and really feel at the centre of their care.
So as you can see there, from people who had heard nothing and know nothing about open dialogue, they went very quickly to a place where they are very, very passionate about it, working very hard, and really making a difference. Now, the first study we published, the first paper we published, was about the experience of people. So we ran little focus groups of people who were in the original pilot team. So my team and the team in Kent were the first teams to run. And we tried to get some focus group feedback in terms of what the experience was like. And what we found is that, this is a quote from the study that we published, open dialogue participants valued experiences of autonomy and having a choice and a voice in their treatment encounters, and noted the collaborative experience of sense-making and feeling validated when clinicians reflected using the participants' own words. So these are all things that were new to those people who were involved in the actual trial itself. And although they hadn't experienced anything like this before, they embraced it very quickly. And actually we have a cohort of service users who have become very passionate about this way of working. So this was a stop-go trial, meaning that we had to answer some questions after the pilot studies in order to get the money for the rest of the study. And if we didn't answer the questions, then we wouldn't get the rest of the money. So the first question was, can we develop a way to offer open dialogue in the NHS that is acceptable to staff, including peers? And the answer was clearly yes. As you saw from that video, the staff were really working this way, changing the way they work and actually implementing the model. Can we develop a way to offer open dialogue in the NHS that acceptable services? Again, yes. Can it fit in with how existing services operate? Again, yes. So it was all feasible. We were able to actually deliver it. It was a good, positive experience for service users. So we were able to prove to the National Institute of Health Research we can now go ahead to evaluate all the other teams which we are now launching. Now we were then hit. So we were running at a fast pace now. All the teams are passionately working away at open dialogue. The evaluation is happening. The academics are on the ground. Our research assistants are evaluating everybody. And then suddenly this thing called COVID-19 comes along and stops every trial, every research in the UK and around the world in 2020. So we had to stop. and we're instructed that only COVID-related studies are allowed to continue. I'm head of research in my own trust, and so I was involved in shutting down lots and lots of studies, including my own. We had already recruited a third of our participants. So what we thought is we want to carry on open dialogue with those people who we've recruited, and let's see what happens at the other end of this pandemic. Will we get through it or not? Now, as the lockdowns ended, my trust is responsible for sponsoring a number of studies. Open Dialogue is just one of them, but we sponsor 7 or 8 studies. And what we found is that most of those studies had to close because you can't furlough research assistants, so the money was being spent without recruiting subjects to the study, meaning the study is going to run out of money and won't be able to finish. So the majority of studies had to shut down, and we were worried that that would be the case for us. We then went to our teams and we said, are you prepared to restart? Now, many of our teams had had staff taken away from them, taken to the inpatient wards and crisis teams to deal with they were literally, the first person who died from COVID, the first healthcare staff who died from COVID was somebody in one of the wards in my own hospital. So they had to go and fill those gaps. So the open dialogue teams are being decimated. And then we came back after lockdown and people are coming back to the teams and we said, look, what do you think? And the response we got was unanimous. Yes, we want to restart. We want to get back to doing this. We want to get back to evaluating it. We want to prove that this works. And because of them and their commitment, unlike almost all other studies in the country at that time, we managed to completely restart and go straight back to recruiting people back on the study, get the planes back in the air, get the teams running and fully functioning straight away. So we persisted. We, like I said at the beginning, we really didn't know if this would continue because of COVID. Now, that persistence has led to a few other studies giving us some inklings of what the future might hold and what might come from this. We don't know for sure. I don't have time to share. You can find videos on there about service users and carers who have been so passionate about the service they've got that they've made videos about them. They're on YouTube. There was like a 2-page spread in The Independent, a major national newspaper, about a network that I work with, talking about how after 40 years of healthcare in mental health services, their lives had been transformed by open dialogue. We have very, very passionate people who've had open dialogue who speak very, very emotively about their experience. And we had an early evaluation. One of the pilot sites, Kent, started to evaluate before the formal UCL evaluation started, and so they were able to publish a paper about this, which showed that this innovative approach provided continuity of care with the social network, with improved carer support and significant improvements in clinical outcomes and their experiences. So a little early sign there that in that early part of the pilot, they had seen positive outcomes. Now we're in the home straight. In October 2021, we completed all the recruitment of all 500 subjects. As I say, this is a very large number for a mental health trial. In mental health studies, you usually don't get to recruit that many people, and we managed to do it by October 2021, thanks to those teams who you've heard from, and the hard, relentless work they kept at it, even through the pandemic, to make sure we keep seeing people at the rate we needed to in order to reach our target. We then wanted a 2-year follow-up. I insisted from the very beginning we have at least 2 years to compare open dialogue to treatment as usual, so we can really show the difference. If you allow too short a time, you might not show a difference, and that might have made the whole thing a waste of time. So we had 2 years to follow up, which ended October last year. And now it's back to the academics. And they are now currently crunching the numbers, doing lots of analysis and lots of maths, and getting the final envelopes ready to open in around October, November this year. Now, as I say, the results will come. Watch this space. I'll come back to talk about them at different places, I'm sure. In the meantime, we do have a conference coming up in London, the 28th meeting on dialogical and reflective approaches to psychosis and distressing mental states. It's the regular Open Dialogue International meeting. People from around the world are coming. It's from the 28th of August to the 1st of September. It'll be at UCL where the trial is being run, and so as you'll meet the academics, you'll meet the teams, you'll meet the people who are involved, as well as colleagues from around the world who are also doing experiments in open dialogue and research and trials, as well as existing services and asking questions. So that's where the community comes together. You're most welcome to come. Email katia.vasco.od@gmail.com. You've also got leaflets on your desk, on your chairs, which Val has been wandering around giving you. So more details here. Now, what have I learnt? Just very quickly to finish before some questions. First thing I've learnt from this journey so far is that it's actually not enough to tolerate uncertainty. You have to embrace it. Because it's only from those unexpected turns of events that inspiration really arises. Inspiration doesn't come from anything predictable or stable. It only comes from the unexpected. So uncertainty isn't just something we should tolerate, it's something we need to embrace if we really want change. Progress into uncharted territory requires one inspiration after another. We could not have predicted we got the grant. We could not have predicted that teams managed to adopt the model and become so passionate so quickly. We could not have predicted that after the trauma of the pandemic, the teams were able to reassemble so quickly. We could not have predicted that the academic team could get back to evaluating so quickly. And there were people from our academic team who died along the way as well. We could not have predicted any of those things. And they all came about because we were able to go forward without knowing exactly what was coming next and embracing that uncertainty. So yes, plan for the future, but hold all plans lightly and never mistake your plans for predictions. Thank you.